Welcome to November. And we have just a few, actually only one announcement from Workforce Health. The masking has started as of November 1st in our clinical areas and patient care areas. If there are any questions about, there are actually now signs up kind of outlining kind of the county regulations on this. So in any case, and with that, I'd like to pass it to Dr. Dunn, who has an announcement for this month for inclusion rounds.
Great. Thank you, Dr. Harmon. Okay. A reminder that the inclusion theme for this year is belonging and making sure everyone in our department can show up to work as their authentic selves and feel like they have a place. To that end, in an effort to respect people's spiritual and world beliefs, we are having an inclusion rounds with the Dean of Religious and Spiritual Life, Dr. Tiffany Steinwert. This is rescheduled from a month ago, but we would love for you all to join us on Tuesday, November 14th at noon. This is going to be a virtual event. She will be helping us be inclusive and respectful of people's worldviews, promoting spiritual wellness and inclusion. Please join us, and you can use the QR code on the screen, or someone will put the link in the chat to register. Thank you, and back to you, Dr. Harmon.
Great. Thank you so much. Just a reminder for next week's grand rounds, or sorry, not next week's grand rounds, for the upcoming, I think, Edward Rubenstein lectureship, which is at the end of the month, November 29th, when we return from the Thanksgiving holiday week. And that will be in person. It's a little bit different than our normal kind of routine of having the first week of the month be in person. So that's November 29th. We'll be in person with Dr. Christopher Walsh as our speaker for the in-person Rubenstein lecture. Okay. And it will be in the CAM building, which is near, right across the street from Lucille Packard Children's Hospital, in the Grand Rounds room, which is on the first floor. So we'll see you there. And with that, I'd like to hand it over to Dr. Kevin Schulman. Oh, sorry, one more announcement. Next week's Grand Rounds, apologize, is via Zoom. It will be Dr. Emily Bender, who will be speaking on the topic of ChatGPT in a medical setting. So please join us for that. And now I will pass it to Dr. Kevin Schulman, who's a professor in our Division of Hospital Medicine, as well as a professor in the Departments of Health Policy.
Well, thank you so much. It's really a great pleasure to introduce our speaker. Professor Liran Einav is Tritone Chair of the Department of Economics here at Stanford, Charles R. Schwab Professor of Economics, and a Research Associate in the National Bureau of Economics Research. As an economist, Liran researches a theory called moral hazard. This is a theory that actually was developed by Kenneth Arrow here at Stanford, who won the Nobel Prize in Economics. And since this is open enrollment, this is a really opportune time to hear from Liran. As you sign up for your health plan, you're going to see different levels of deductibles and copayment and coinsurance. They're all designed to respond to this theory of moral hazard. Liran, together with Amy Finkelstein, MIT professor of economics, who's also one of the country's leading experts in insurance design, have written a new book. We've got you covered, Rebooting American Health Care. And he's got a big surprise for all of us in terms of his new thoughts on insurance design. Liran's an incredibly distinguished economist, co-editor at the American Economic Review. AER is the top economics journal in the world, Econometrica. He received his undergraduate degree in computer science and economics from Tel Aviv University, and his PhD in economics from Harvard University. And it's such a great pleasure to have him with us here today. So Liran, thank you so much for joining us.
Thanks a lot, Kevin, for the intro. Let me show you the slide. All right. So thanks, Kevin, for the nice intro. Thanks for having me. As Kevin, he already took some of the punchline kind of too early, but so this is the book that we just recently kind of wrote, like last summer it came out. I have 3 copies in my office if people want to read and don't want to pay. And let me just start with a little bit of a background of what got us to write this book, so you kind of understand where we are coming from. So I'm in economics, as Kevin mentioned. I've been at Stanford for 20 years. I've been working with Einav at MIT for like 17 years of these 20. And basically, historically, we've been studying, kind of small, narrow issues that we thought we can say something about, and maybe policy can actually tweak stuff to make things better. And sometimes around the 2020 kind of Democratic primary campaign with the Bernie Sanders kind of Medicare for All campaign and stuff like that, it was sort of a lot of talking about, okay, what should kind of the healthcare system should be, and we were being asked, like, what do you think? You've been working on healthcare economics kind of for quite some time. Do we like Medicare for All? Do we don't like it? Do we think something else is better? And we had like nothing good to say. I mean, it's like, oh well, it's complicated. It's a messy system. It's like it's hard to kind of solve it. It's like really different moving parts. And what do we know? But then somehow we kind of came to the conclusion that it's kind of a little bit sad that sort of we've been working on for 2 decades on this type of problems, and we have nothing to say about this kind of basically very natural problem. So we started thinking about it, and then COVID hit. It was like, and then we were like, okay, we have like even more time to think about it, and we decided to write this book when we realized we have something to say. And what this book is about, and in that sense, it's kind of one way to think about this book is a bit of a blue sky attempt to think about U.S. healthcare. It's very U.S. specific, but it's really trying to, maybe kind of, lean in hard on we are academics, we are not policymakers. So maybe at least for the next hour, we can ignore for a second all the political, constraints and, politics that is involved in making any changes in healthcare, and try to ask, okay, suppose we could do whatever we wanted without any political constraints, but with some economic and budgetary constraints. What is it that we want to do, and how should we kind of, fix the U.S. healthcare system? So that's basically the plan for the next hour. One thing I should say, I'm in economics, as some of you know, in economics, people start yelling at you at the title slide, and talking 30 minutes straight without any questions is kind of make you nervous. So feel free. I know that I'll keep some time for Q&A in the end, but feel free to kind of maybe through Kevin or just jump in and ask questions if anything comes in kind of as I talk through stuff. Right. So I'll try to walk you through kind of the basic points of the book. The way the book is organized, it basically has 3 different parts. Quite often people gravitate, Kevin already gravitated to this, like, of what are we proposing, which is like the 3rd part. But let me, I guess the way we wanted to think about kind of structuring the conceptual thinking of the book is not to say, okay, what are we proposing? But that sounds a bit like politics to me, but more like, what are we trying to do, and why are we trying to do it? And then sort of hopefully the proposal is going to be kind of natural to people if you agree with our arguments. So the first part of the book is trying to look at the current US healthcare system, and if you guys are very familiar with at least on some angles of it, and try to shrink it to, okay, what are the issues, and is there a way to fix them in an easy way? And then the basic conclusion from that is going to be that just more tweaks have been tried and have not been working very well. So maybe it's time to just scratch it all completely and start from scratch. And then the second part is basically, okay, if we are going to redesign the entire healthcare system from scratch, then before we start building something, let's decide what is this kind of construction is supposed to deliver. So the second part of the book is trying to engage in what is it that U.S. healthcare system or U.S. health policy. Again, most of the focus of the book is less about the delivery and more on the what type of health insurance coverage people should have or the government should be providing. So the second part of the book is like, what is the purpose of all this all this kind of endeavor, and the third part is basically, okay, so given all of this, what is kind of a proposal? And as I said, it's not going to be a play-by-play sort of instruction of what to do, but it's going to be a very high level sort of conceptual building blocks of what we think kind of should be basically the ideal sort of US healthcare system that is also kind of something that we can afford. So let me walk through kind of each one of these parts kind of slowly. So let's start with the current system. So two things about that. So the most common thing, if even if you might not see this as on a day-to-day if you're at the Stanford Hospital and dealing with patients, but the typically when people talk about what's wrong with the US healthcare system, the most common thing that you hear and that is being discussed is like, oh, we have like 10% of the people are uninsured, which is horrible. Like no other country, which is true. I mean, sort of no other country has like, uninsured. What other developed countries have like, coverage for everybody. And in the US, we have like 10% of the people uninsured. It used to be 20% before the Affordable Care Act in 2010. So in that sense, sort of, this is a big problem. The two other problems that to us are just equally important and are not discussed as much is one is the idea that, even the people, so of the 90% that are insured, they keep, many of them keep losing their coverage. So one work that we did in our kind of, in our research is to look at of the people who are getting sort of some sort of health insurance coverage through employer provided, through Medicaid, through through kind of private exchanges, within 2 years, 1/4 of them is losing their coverage. And that could be from very different reasons. There are many, it's incredible how many ways you can lose your coverage because you are making more money, so you're kind of not eligible anymore for Medicaid. You can lose your coverage because you just lost your job, you got ill, you lost your job. At the time of losing your job, you also sort of lost your kind of employer provided coverage. You could lose your coverage just because you recovered from a disease because there was some disease specific coverage. So a gazillion different ways to lose your coverage, and it's kind of a crazy problem, especially in the context of insurance, because if you think about insurance as from an economic perspective, at least, insurance is something that's supposed to, it's not going to cure you, but it's supposed to at least make you not worry about your financials kind of when you're getting sick or a family member is getting sick. It's kind of crazy that sort of, the insurance itself is being very uncertain. So the thing that is supposed to give you more certainty about your future is actually itself uncertain. So that's one second problem, other than just how many people are uninsured. And the third problem that, is also kind of unique to the US, and you don't see it almost at all kind of in other developed countries, is the idea that even if you are insured, many people, not everybody, but many people who are insured are basically stuck with a lot of medical debt. So medical debt in the US is a thing. I mean, I'm sure you know this from patients, you know this from advertising on TV. Like lots of companies that try to help you deal with your kind of consolidate your medical debt, pay your medical debt, and stuff like that. That's because it's a big thing. Instinctively you think, well, that's natural, because if many people are uninsured, then they can't pay for their health, and then sort of, they're getting stuck with medical debt. Another shocking fact that we kind of found out, not our work, one of my colleagues, Neil Mahoney, one of my colleagues work, is that if you look at all the medical debt in the US combined, more than half of it is basically by people who were insured at the time that they had their healthcare kind of, utilization. So about 60% is basically not because people were uninsured when they had some healthcare expenses, but just because they had like huge deductible or really high copays. So if you think about Medicare for all, for example, this jargon, it's like Medicare, at least the most basic Medicare coverage, doesn't have too much deductible, but it has a 20% cost sharing. So for every dollar you get billed, you pay out of pocket 20 cents. And if you're an elderly and have several kind of chronic conditions, that means you're like at tens of thousands of dollars a year in terms of medical bills, which means that you're on the hook for like $5,000-7,000 out of pocket. And for many elderly, that's kind of way too much to afford, so they get stuck with different medical bills. So like a third problem of the current US healthcare system is that even the insurance that many people are provided is not really helping them kind of get the financial security that it's attempting to deliver. So what do we do about it? So Medicare and Medicaid started in the mid-60s. You know, they were not perfect. They were like basically kind of good attempt to start, you know, dealing with these issues. And then since then, you've seen sort of a lot of attempts. So some of these problems that I just alluded to, they are not, we are not discovering them. These are problems that many people were acutely aware of, kind of for a variety of for many years, in many places. And if you look at US health policy, many of the changes that were made in the system since going back to the introduction of Medicare and Medicaid in the mid-60s were like attempt to kind of fix different gaps in this type of system. So just these pictures are going to give you some sort of attempt. So this one, this is what they call like a life of the death committee. That was like when they came up with dialysis in the early 60s. Dialysis was way too expensive for people to get it covered. So lots of people died with you know with kind of end-stage renal disease because they couldn't sort of get dialysis kind of covered for them. And then they came up with a committee that basically tried to decide who gets dialysis and who doesn't. It took like from the early 60s when they started, and then Medicare came in, and then by 1972, with a lot of sort of both politics and sort of other news events, by 1972 they decided to cover ESRD, so any patient with end-stage renal disease get bundled into Medicare. So Medicare is that, I think you guys should know, like sort of if you're at 65 and above, you get covered, but suddenly sort of ESRD patients also became sort of part of Medicare. So even if you're like a 45-year-old, you got ESRD, you were part of Medicaid, and that's great. Obviously, sort of it costs money, but it gets coverage for people who cannot otherwise afford dialysis treatment. It has two weird things. One, if you are uninsured, for example, or badly insured, all the stuff that got you to the end-stage disease, like if you had some kidney functioning issues and stuff like that, that doesn't get sort of covered, kind of if we are like one of those who are not well covered. So that means we are waiting for you to really get to a bad stage of the end stage renal disease when we decide to cover you. The other one is that sort of once you are not in an end stage renal disease, suppose you were lucky enough and you got sort of a kidney transplant, then sort of now you're out of the ESRD kind of group. So if you're like under 65 when you got a kidney transplant, now you need to still pay for the for the different sort of the medication that you need to take with immunocompromised kind of kidney, and sort of nobody covers this. So again, you have this weird stuff that sort of it's a very disease specific kind of coverage that covers you kind of only once you become sick enough, and then stops covering you once you kind of get better. Another case is and let me skip this one. Sort of Ryan White, that's like a kid that had kind of got infected, with HIV, like in the late 80s, early 90s, and then there was a big deal about like he wasn't covered, and then his parents couldn't pay for his medication, and then again they added sort of for low-income people, they added like another patch to the current system by basically saying if you are a low-income kind of HIV patient, then we cover you sort of to make sure that you can afford the medication. That's like Ronald Reagan sort of, in the early 80s, there was basically if you're under Medicaid, that's the coverage to the low-income people in the US. Basically, there was this rule that sort of if you are a kid that is institutionalized, then Medicaid coverage remains, but if you are kind of going home, then sort of you lose your Medicaid coverage. And then there was this kind of this kid, she was kind of 7 years old at the time when it happened, that basically their parents had to kind of keep her kind of in the institution, even though they wanted to kind of treat for her at home, and basically sort of they came up with different patches to allow kind of when kids kind of at home with this type of disease, they basically sort of, cover them. So they keep adding, and then actually that's like a funny or kind of not so funny story that sort of, over time, sort of the technology of treating this disease kind of got better. So suddenly these kids that didn't have like huge life expectancy at the time started like living longer, and this Katie Bennett patch kind of she actually ended up kind of living to the mid-30s. The minute so despite the patch, they allowed coverage when they were at home, they lost this coverage once they got 18. So you have like a patch that kind of ended up not working as well. And then you have the other case was the ALS thing that some of you might remember from the ice bucket challenge. So lots of sort of different cases of sort of, we have a system, we like Medicare and Medicaid, they are doing well for some subset of the population, but they leave sort of some gaps for other types of the population. So over the last 5 decades, what you see quite often is that sort of, you keep coming up with some new disease that is potentially treatable. This could get triggered either because you have like a new technology like dialysis that suddenly can cure certain things that were not curable before, or it can come from basically some sort of political campaign because some famous guy or some sort of politician or something like that kind of brings kind of up this particular disease. And each case is a third case, but you keep building these small patches, often like disease specific or income by disease specific conditions that add people to the medical coverage or Medicaid coverage. But it's not being done in a very systematic way. So then you have kind of cases where some, another case I didn't mention, like at some point there was maybe certain types of cancer, people had, and people couldn't get them, detected. So because they didn't have access to preventive care because they were not insured. So then the government came up with like a new program that basically allowed low-income sort of women kind of get kind of a free mammogram to kind of get kind of breast cancer. But then the problem is the same woman that got sort of government covered sort of mammograms couldn't have the money or didn't have the insurance to kind of to treat the breast cancer if it was discovered. So then they created another program that basically said, well, if you detected the breast cancer under this program, then you will also cover you'll cover it. But that means that we only cover breast cancer treatment for uncovered adults if they all happen to have the mammogram done under this old program. And then if there are like other types of cancers, then we wouldn't treat them. So everything was a very petty thing. So on one hand, we have two conclusions from that. Basically, that's the end of the first part of the book. The two conclusions are, one, this patching is not working very well because it's like you start a house and you keep kind of, keep adding rooms to it in a very disorganized way. Then kind of after 50 years, you get this kind of patchy kind of thing that doesn't kind of make sense altogether. The other thing is it does prove kind of what we are trying to do, and that's kind of going to lead to the second part of the book, which is, what we are really trying to do is that we don't want to let people sort of die if we think we can kind of save them in some sort of sense. So that's kind of the conclusion from this kind of little story is that the instinct to keep patching the system and keep building more kind of little fixes to different issues that keep arising kind of from time to time, and we think that after 50 years of doing this, it's pretty clear that it's time to kind of rethink the entire system and try to do the same thing, but in a much more organized and kind of centralized way, rather than kind of wait for some trigger that is going to trigger the next patch. And as I mentioned in the beginning, so once you start thinking about, let's see if we're going to redesign the system from scratch, how are we going to do this? So before we start designing something, let's start thinking about what is it trying to accomplish. And basically, there are many reasons that people mention as like, oh, universal coverage should be because of that and should be because of that. But the one thing that basically we came to realize, and again, you see it from the patches that I just discussed in the last slide, like all these attempts to the policy patches are kind of a bit of a proof that sort of what the policymakers are trying to do is essentially to try to help people who cannot kind of take care for themselves, especially at the kind of life-threatening sort of type of diseases. And you see it in other ways. You see it, when we talk about the uninsured, I mentioned in the beginning, everybody talking about, 10% of the Americans are uninsured. That's horrible. but actually, in some way, the issue is not really that people are uninsured, because if you look at sort of the uninsured, they are getting some access to care, which is not, it's not great, but it's not nothing. One evidence is coming from from the Oregon healthcare experiment that actually my collaborator Amy kind of was one of the kind of lead investigators on. They ran basically a lottery in Oregon, wanted to expand their kind of Medicaid program about 15 years ago, but they couldn't afford kind of expansion of the program that would cover everybody would be eligible under the new kind of expanded sort of coverage. So they decided to run a lottery of who gets the expansion or who doesn't. So we had like a really nice kind of RCT about who gets kind of Medicaid coverage and who doesn't. And there are many things you can draw from this, but the thing that I want to highlight here is that basically, if you, after the fact, if you look at compare people that basically got kind of new coverage under Medicaid at Oregon versus people who were lotteried out, sure, the people who got coverage are doing better and are using more healthcare, but it's not that the uninsured people who were eligible for the expansion but just got lotteried out are getting nothing. They end up getting basically 80% of the healthcare kind of that the insured people are getting, they're getting, and they're paying not all of it. They're paying basically 20% of it, which is like similar to kind of an uninsurance kind of to a regular insurance policy, not a great insurance policy, but some insurance policy. And the reasons they're getting it, and again, some of you kind of are in the hospital probably know this kind of on a day-to-day basis. You know, if you come into the hospital uninsured, you know, they'll treat you, and then sometimes they wouldn't even send you the bills. Sometimes they'll send you the bills, but not really expect you to kind of pay this. So there are many systems in the US that are trying to kind of incentivize providers, especially hospitals, but also community clinics and other kind of providers, to try to take care of the large share of the population that are uninsured. And one thing that surprised us, kind of actually doing all the research for the book, is how, you know, it sounds like sort of, you know, covering for the uninsured seems like a very kind of patchy system and a lot of, you know, volunteer work and stuff like that. But there are tons of formalized instructions and policies at the federal and state level that are basically trying to kind of, you know, systematize the coverage that sort of the uninsured people are getting. So in that sense, you know, even though we call them uninsured, they are kind of insured, but they're insured in a bad way, because kind of all the systems are working through providers instead of going through the uninsured themselves. So you put it all together and you look at some of the more philosophy things that are kind of written all of it, and it seems like that the main reason that, you know, us as a country are thinking that this guy kind of, you know, should get some sort of coverage. It's basically some philosophical sort of idea, which seems kind of, at least with us, resonate quite well, is that, well, we want, you know, we don't want to let creatures kind of, you know, die in the streets. So we want to take care of them when we can. It's not a new idea. It's an idea that was actually going back actually to the US, back to the late sort of, you know, 18th century. When at the time, sort of basically healthcare was very different from healthcare today. The main issue for healthcare at the time was like basically just to care for patients who are falling ill and in some sort of with the bed and some sort of, you know, dehydration and sort of the issue at the time was that, well, you can just go home, but then, you know, sailors was a big problem for what used to be at the time the healthcare system, because, you know, in the late 18th century, sort of lots of people were basically walking off boats as sailors, and then once they got sick in the port where they arrived to, they had no family members to take care of them. So then actually the first guy that actually came up with, like, you know, universal healthcare, if you will, is Alexander Hamilton at the time, who basically instituted like the first kind of, I think, in the world at the time, sort of universal insurance system, which basically said, like, basically all the ships are going to pay some sort of upfront, you know, fees to cover all the sailors. And once the sailors get hit, you know, with the disease, then basically we are going to be able to fund sort of the taking care of them through kind of local hospitals. So the basic idea that sort of let's take care of this kind of early on before things happen, that's kind of, you know, go back like, you know, all the way to Hamilton. And the basic idea also kind of stays together, and it's not like a political thing. You say universal coverage. When we started writing the book, we were worried that people will think that's kind of a very sort of liberal type of view. But you see some basic level of this idea from kind of RBG, that sort of basically she said it kind of, but also Mitt Romney when he was the governor on Massachusetts. He instituted the Massachusetts kind of health insurance system in 2006, which was like preceding the Affordable Care Act, and he also kind of created this universal coverage. And even scholars in the Heritage Foundation, talked about sort of this idea that sort of we don't want to let people kind of die in the streets, kind of when we can cover them. So that's kind of where we are heading. Sort of that's the main reason that we want to institute some sort of U.S. healthcare policy. And the last thing I would say before I go to what we are going to propose is that quite often when we talk about, okay, let's redesign the healthcare system, people think about, okay, that's going to do multiple things, including sort of, kind of reduce inequalities and disparities, in health across low income and high income, across kind of blacks and whites, and vice versa. And one thing that sort of I think important to note, and there's a lot of empirical evidence about it, is that sort of providing universal coverage, it's going to kind of solve some of the kind of inadequacy of the coverage that people get, but it's not really going to kind of solve for kind of disparities. I think it's like enough evidence out there that sort of health disparities are not as much driven by the healthcare itself. Even the people who are uninsured eventually get access to healthcare in some way, but most of the health disparities are kind of coming from kind of different kind of health behaviors like drinking and smoking and exercising and pollution. So that's kind of the picture here is like that's like an old paper by Vic Fuchs who basically talked about comparing Utah and Nevada population, two similar population in many ways, but sort of life expectancy in Utah is much higher than Nevada, and he attributed it to basically very different life behaviors. And there's like a lot of evidence from more kind of recent sort of data and much more kind of rich data kind of in the US from other from other countries. You look at papers in Sweden and Norway, which are much more kind of equal countries in terms of income and social kind of in welfare countries, and still you see sort of big health disparities across multiple sort of dimensions. So this is not like a goal for us, at least as we design the healthcare system. And then finally, quickly, what are we proposing given all of this? If I had to summarize our proposal, it's kind of pretty easy and pretty simple to get, and we can dive into this kind of in more detail, either kind of in the next 10 minutes or kind of in the Q&A. But basically, if we're trying to design a system that is going to make sure that people don't die on the street and we can save them, the way to do it is not to wait until they're dying half dead in the street and then we try to save them, but to do stuff up front and more universally. So our basic kind of point is like we should have like a two-layer system. We have a basic coverage that is designed to basically deliver the social contract, deliver the idea that everybody should have access to healthcare that is basic and prevent them or allow them kind of the most basic sort of healthcare needs. What it means, it needs to be automatic. Right now, sort of, even when we cover people, not always they get the coverage because they are not, either because of the patchy system of the US, not everybody who is eligible for coverage actually is aware that they can get the coverage. Sometimes kind of people are aware that they can get the coverage, but just applying to the different types of coverage that people can get afforded. The application process or the recertification process is way too complicated and too messy and too much paperwork that many people actually just either give up or can't go through this. So our proposal is basically to move to something that is much more automatic. So something like you get born, you get your social kind of before you're a week old, and you also get your kind of healthcare card at the same time, and basically you're guaranteed as a US citizen you get automatic coverage. The second part, which is I guess what Kevin alluded to kind of in the very beginning, we make a big point that it should be free. What should be free? It means that you don't want people to pay for it up front, because once people pay for it up front, not everybody can pay or do pay, and then you end up again with kind of non-universal coverage, and you need to deal with the people who don't have coverage. And also, we don't want people to pay sort of any co-pays or co-insurance rates, because what you see from many kind of cases is that sort of once people can't pay, then even $5 or $10 make people not go to the doctor for something they need. And at that point, sort of we are also stuck with people who should have gotten something done, but they haven't gotten it done because of different sort of, copay issues. And then we need to kind of come up with ways to kind of take care of it. The argument that was like a big thing for us, at least as economists, because as Kevin mentioned in the intro, we've worked like for 15 years, partly on kind of different sort of financial incentives and co-payment rate and deductibles and so forth. And then what you see, part of the reason we change our mind, at least in the context of basic coverage, is that if you look around the world, economists for 20, 30 years have been kind of lobbying for like more skin in the game for patients because of what we call moral hazard, of people kind of using too much care when it's free, and we need to kind of limit it by making them pay a little bit out of pocket. But what you see is that sort of in many countries, they get stuck with basically we keep introducing more kind of co-payment and co-insurance rate and deductibles, and then not everybody can cover it. And then two things happen. Either like something like in the UK, for example, they introduce kind of co-payments for kind of medications, and then slowly they realize that like enough people can't actually pay the co-pays, so they gave exemptions to the point that now more than 90% of the prescription drug co-pays kind of in the UK are basically get exempted. So you introduce the co-pays, and then you take them out through a complicated layer of exemptions, and this happens in many other countries. Or the other part that you see, France is a good example, where you introduce a lot of co-pays and co-insurance rates, but then people get the same original problem of people wanting health insurance. Now they get sort of insurance against the co-pays, so then you end up either a government provided or a privately provided entity that insures people against the co-pays. At that point, sort of the co-pays are not delivering sort of the economic incentives that we originally wanted them to get. And then some people would argue, so maybe we should at least make it not zero, but a little bit. But then once it's a little bit, then it's not doing anything. Either it's not kind of saving anyone money, or it's not kind of, providing enough incentives. So at that point, at least for basic coverage that we think everybody should get access to, we think you should just get it, get it automatic. And when you're born, you should not pay anything for it. And even at the time of care, you shouldn't basically kind of pay any co-pays or anything like that. But then, how do you fund all of this? How do you make it happen without just giving people too much stuff? Well, you need to make it basic. You need to define very carefully what we mean by basic. And basic means like, the social contract doesn't mean that you get like a private recovery room after kind of, labor and delivery. It means that, we do the necessary medical part that we think as a society we should give you, and sort of everything beyond that, that's kind of not covered anymore. That's not part of basic. It doesn't mean you cannot get it, but for this you need to pay. Now it's more like a normal economic good, kind of all the upgrades, either in terms of like the amenities that are associated with any medical care, or even the choice of a doctor, or the location of your kind of, radiation therapy, all this stuff, that's something that we feel you can sort of separate to a supplemental coverage when you can pay out of pocket for kind of, higher level of care, which higher level either mean some version of quality or comfort or kind of recovery. And then so that's basically that's the point about the free that I just talked about, that it goes back to when they introduced, it wasn't like an obvious thing, like when they introduced Medicare in the US in the mid-60s, kind of there was like a Nixon and Ted Kennedy kind of debated whether it should be free or not, and in the end sort of it wasn't free because one of Nixon kind of won. I guess we are taking it back at least. And the basic stuff is kind of what I said, like let's just kind of there's like a lot of push in the US for basically comfortable healthcare. We are totally for it, but we think that we should separate the most basic needs that we think we should cover. We should make them free, and then all the extra stuff people should be paying out of pocket. So that if they want to, you can buy a private insurance that pay for these upgrades or for this concierge medicine. But this is not part of what the kind of as a society we should be basically covering also. It's not part of the social contract. And one analogy here is if people kind of travel by airlines in Europe, I mean, I guess we are thinking about U.S. healthcare to be provided for free, the EasyJet or the Ryanair experience, where it's really crummy, it's really bad, but it's really cheap, and it does get you kind of from one place to the next, and so it's been really effective. And everybody can kind of upgrade for business or upgrade for kind of nicer kind of airlines, but at this point we don't think that health policy should have anything to do with it, so we can run private markets to cover all of this. And then you ask, can we afford it? And that's a statement by Vic Fuchs. He's like an amazing, even like the father of health economics. He just passed, actually. We released the book in July. He passed away like in September. He was a Stanford kind of economist. He was 99 when he passed away. This is a sentence from him. Almost every American family has become acutely aware of the soaring cost of medical care. According to many observers, the US healthcare system is in crisis. The thing to note here is that he said it in 1974, 50 years ago. So many people, when you start making changes in healthcare kind of policy, we're like, oh, we cannot afford it, we're already in crisis. I guess we want to use this to point out that basically for 50 years, people said the US healthcare system is in crisis. Costs did rise even when we tried to stop them. So it's less about the cost. We think we can afford what we propose more or less at the same level of expenditure that we are currently providing, because we are offering you to kind of to cover more, but cover more kind of the dollar, but kind of make things kind of more basic. But the other point is to say, let's first decide what we think as a country we should deliver, and then we can worry about kind of the cost later. Kind of, if we're a rich enough country, we can decide what the priority is first. And then, as I mentioned, it doesn't mean that every get basic, Medicaid people probably would keep getting more of the same. If you're a Stanford kind of employee and you get the Stanford coverage, basic would be much less than what you're getting today, but that doesn't mean you're getting kind of downgraded. It just means that you need to pay up kind of in order to get kind of the nicer care. And then the final thing before I kind of stop for Q&A, many people kind of think, well, these guys are crazy. They're like two economists, they have no idea what policy is and what politics is, and like no way to get there. We are not claiming that we can. We are not claiming that we know how to do it. But the one thing we are going to basically, and that's the way we end the book, the one thing to remember is that when people talk about the US is the only developed country in the world that doesn't have universal coverage, that's correct, but it's not that like all the other countries have been having like universal coverage forever. Some countries like from Germany in 2007 and Taiwan kind of 15 years ago, and Australia in the late 90s, all of them went into universal coverage in the last several decades. So it wasn't like they were kind of destined to kind of basically always have universal coverage. And also when they went through universal coverage, it wasn't easy. Like they had a lot of demonstrations, in the UK when they came up with universal coverage, kind of, there were like a big medical strike, and Canada had the same situation. So every country that went into universal coverage, they also thought it wouldn't be possible. And in the US, it wasn't that far from some version of universal coverage when kind of Nixon had his first plan in the 70s. Or when Clinton had kind of his kind of health plan in the 90s. So all we are saying is that sort of the fact that we are the only country that have no universal coverage doesn't mean we are destined to be one. I mean, it just means that we maybe kind of just got kind of in our view, like the wrong side of the stick. So that when kind of you let kind of the different political forces kind of play out. So doesn't mean it's possible if we don't know how to get there, but we think there are many ways to get there. And at least that's something we should aim. Should we get there immediately? Should we get there in steps? I mean, that's kind of for the DC people to kind of think about. But the way we think about this entire kind of book is okay. At least we should have when we start talking about kind of healthcare policies and different tweaks or bigger or smaller. At least it would be useful to have in mind some sort of destination that we all agree we should get to. And this book is the attempt to kind of defining some sort of such a destination. All right, I should stop here and basically take some questions.
Liran, thank you so much. That was great. I got a couple of questions that have come in already. But I want to, maybe I'll take 2 seconds to go back to how much of a shift you're proposing. You and Amy, I said at the beginning of moral hazard, this is underlying the design of health insurance in the United States, maybe uniquely. High deductible health plans are in a third of the market, you know, and all based on the Rand health insurance experiment. And you're suggesting in the book that we took the wrong conclusion from that experiment. This 50 years of data since the Rand suggests that, you know, that probably wasn't the best design. So maybe you could chat about that for a second.
So yeah, so let me just thanks for asking, because I think we're not saying that the research was wrong. That we are totally, well, again, part of this research is ours, so for sure we're not saying it was wrong. It's still true. Sort of, if you go back to some of the debate early on, the debate was basically, if you go back, I mentioned it quickly, there was this Kennedy-Nixon debate. The debate was, you know, I think there was a Malcolm Gladwell piece at some point, so like the moral hazard myth. The debate was there, like, you know, is there sort of, you know, financial incentive in healthcare? Because the conceptual point people made was, well, if you're sick, you need to take care of it. It doesn't really matter who pays for this thing. You just need to go to the doctor and have kind of this taken care of. Like tons of evidence going back to the health insurance experiments from the late 70s to a lot of our own work was, no, that's wrong. I mean, sort of, you know, the demand for healthcare is in many ways just like the demand for apples and bananas. You make the price higher, you know, price to the consumer, the out-of-pocket price higher, people use less of it. You go less to the doctor, you do less, you know, like what we call, like in economics, demand curve slows down. So you can control a little bit, at least, kind of the utilization by changing the out-of-pocket price. And in the US, the way you change the out-of-pocket price is either by deductibles and by kind of copays and coinsurance rates. So the argument that we're making now is not to say, okay, let's go back and all this work was wrong. The argument, yeah, this was right, but so at least in the context of basic healthcare, by which we mean in the book, we have a lot of examples. I have to think about what's basic and what's not basic. But for basic healthcare, we feel like there's like a lot of sort of, you know, evidence that countries around the world feel like we need to deliver basic healthcare for everybody. So if people cannot pay the deductible or cannot pay the copay, then we're going to find other ways to kind of, you know, to give them exemptions or to give them sort of coverage against these copays. And once we do this, then we are undoing the financial incentives anyway. So why do we need to go through all this kind of shenanigans of kind of introducing something and then taking it out? It creates lots of red tape, lots of complicated system. We might as well kind of realize this up front and take it out. Once you go to non-basic coverage, that's less of an issue. Like once, you know, if we feel that sort of, you know, everybody gets basic coverage and then people can pay up, then I'm all for kind of, you know, deductibles and copays, because at that point, if you can pay for it, it's fine. You still get the basic for free. So I'm not going to go through crazy kind of, you know, exemptions and others to make sure that you're allowed to get the supplemental stuff. So once you get the basic, then I'm back to kind of our standard kind of economic system of basically, yeah, introduce cost sharing as much as you want, because that would control sort of demand for something which is not necessarily unnecessary for everybody.
Well, no, that's great. Thanks. We're getting quite, so Stanford's a tertiary quaternary care center. We have a beautiful new hospital building. We provide a lot of really aggressive cancer care, but we provide a lot of advanced imaging services. And so some of the questions come in about would these service, you know, in the book, you talk a lot about single rooms versus double rooms and amenities, but how would this impact the clinical service we're providing? Would specific question like, would an MRI be basic? Are all my patients I'm on hot rounding this week? One or two advanced.
No, totally. So again, I kept talking about basic. I intentionally didn't go deep into kind of, okay, what's exactly basic, and is this particular MRI or that particular imaging is part of basic or not? And for two reasons. One, when you write a book, you know, it's kind of not a fun chapter to read. If it's like 40 pages of kind of itemized kind of services by condition that decide, okay, basic, not basic, and that's one reason, it's just boring. Two, we don't feel like sort of, that's some cases are obvious to us. We think that, preventive care and sort of primary care and appendectomies, they for sure part of basic. We think that sort of, aesthetics kind of and plastic surgeries kind of should not be part of basic. That's kind of obvious. There are many cases that are kind of in between in a variety of ways. Like, let me pick one example from an earlier paper we wrote. Take like breast cancer. You can do mastectomy, you can do lumpectomy with, follow-up radiation. The mastectomy is cheaper. Not by a lot, but it's like, I think, the number that we got at the time was about total cost for mastectomy was like 40K and lumpectomy with the radiation was about 50K. There was no strong evidence that sort of, at least from a survival perspective, one or the other is better. From aesthetics, or from the patient kind of feeling, there are like lots of demand for kind of lumpectomy because it preserves the breast. Should this be part of basic healthcare or not? Well, that's a question. I don't think it's not obvious. I mean, some people are like, no, as long as it, allows you to keep functioning and stay alive and without any better kind of chances of kind of dying from this, then that's fine. But not, some people are like, well, but preserving the breast, that's part of functioning. So it's not an obvious kind of answer. And the other reason is like, whatever is obvious now might not be obvious kind of in 10 years because of technology is changing. So the main point in the book is like, let's not define basic here, but let's just make sure that we have a coherent process of defining what basic is. And we go in the book through kind of, Oregon actually had a bit of a process like that. The UK, the National Health Service and the NHS in the UK has a bit of a process like that. And basically the way that these processes work is that you kind of define a long set of kind of services and conditions. You cost them out by how much they cost and how many patients we expect to need them in a given year. And then you figure out which ones of them are the most, the most important under some sort of budget constraint. And obviously sort of what goes into basic is going to be bigger if kind of you have more budget. So there's like a bit of a political decision of how big the budget for healthcare should be, and a little bit of a philosophical view of sort of, between different sort of, gray area type of services, which one is more important. They're like economists, at least we don't feel like we have any monopoly on this type of decisions. And that's kind of a society kind of decision to make once we go into the less obvious cases. So that's basically where we are.
Yeah, I mean, actually, it's interesting because it's not in the book, but one of the things that in my work right now, we come to the conclusion like no one is in charge of U.S. healthcare. No one even, it's barely anyone understands what's going on in the U.S.
Yeah, that's part of the when people talk about Medicare for all, Medicare is in one way it's great because that's kind of the closest you can get. That's why they're using it for the jargon, because it's kind of, at least once you become 65, you lose the uncertainty about insurance. That 65 and up, you get coverage. On the other hand, one, it's bad because you have this 20 cents on the dollar out-of-pocket spending, at least the traditional Medicare. That's kind of way too expensive for many elderly. On the other hand, it's horrible from an economic perspective because, like, basically, whatever the doctor does to you, Medicare pays. And there's no gatekeeping. Again, gatekeeping sounds bad, but gatekeeping is a substitute to kind of more deductibles and more cost-sharing to make sure that we are kind of giving you what you should get, but not more than that. Because if the doctors are just, and I guess many of you guys are signing up on anything that's useful for the patient because the government pays, that's how kind of the healthcare budget goes kind of through the roof. And there's like there's like no system. It's not that nobody, like there's like no system there to actually monitor kind of this budget, because basically it's once you get Medicare, you can get whatever the doctor signs off on, and you get it paid. Nobody kind of checks it, like unlike sort of other type of insurance.
So one of the questions we have is interesting. There's a lot of work Betsy Bradley's done on the relationship between medical insurance and social insurance. And so one of the questions stepped into this. how close are we having to have medical insurance pay rent for the homeless? The kind of patients that we have that come in every month or every 3 months to the hospital, how do you draw a distinction?
Yeah, so that's a good question. We have a tiny bit in the book about this, but on one hand, it's the same. Like if you think about housing services and other stuff, it's all the same. The one thing that is very different about health insurance or healthcare, which makes it distinct, is the point that I kind of made before, which is basically there's something about healthcare. When people don't have a house to live in, we are not jumping through hoops to make sure they get into a house. We might offer them some shelters and stuff, but look, I mean, we are all kind of going to San Francisco. The streets is full. It's awful. It's sad, but you don't see kind of government programs, chauffeuring people from the streets to some sort of, hotels. In healthcare, when people start being sick and kind of dying sick on the streets, there are lots of sort of, programs, society kind of instincts to just get these people into the hospital and take care of them. So in that sense, we need to, when we design this kind of, in economics, this kind of Samaritan dilemma, when we realize that sort of eventually when people cannot pay for their care, we are going to find a way to try to rescue them. This is much more in healthcare than in other kind of, context, other social insurance contexts. And in that sense, that put more kind of a need to have an upfront payment to the system. So it goes back to one of the, all the UBI people are like all this discussion about universal basic income. The idea was like, well, everybody should deserve something, so let's give everybody, I don't know, 15K, every quarter to do with it whatever they want. That would guarantee that everybody can eat and drink and find a shelter and get healthcare. But then even the most kind of conservative cases that pushed for kind of universal basic income, they're like, no, but let's leave some of this money off the universal basic income and keep it as a healthcare kind of budget, because kind of if people are going to spend all this 15K they got kind of on stuff and then they fall sick and cannot kind of pay for the healthcare, what do we do then? Because we feel like as a society we need to take care of them. So this kind of ex post, ex ante kind of thing, it's much more relevant in healthcare than in all these other kind of non-health services.
Great. Well, Errol, I think we have a whole bunch more questions, but we're at time.
I can stay if people want.
Oh, great. Let's stay on 1 or 2 seconds.
Thanks everybody for coming, for those who need.
Yeah, Liran, one of the questions that we have is like the workforce issue. So what would happen, again, selfishly here at Stanford, the basic, would the supplemental services get paid higher rates? Would doctors migrate to provide supplemental services compared to basic services? We already see that, in federally qualified health centers versus working for us. But how would the workforce work out?
Yeah, so two things that thanks for asking, because so one thing, when I didn't say it in the talk, but let me use this question as an opportunity to say it. When people come up with healthcare proposals through the last multiple decades, typically they talk about both kind of, let's change the way we provide coverage, and let's talk about how we do this, through, public versus private, through sort of, single payer versus multi-payer. Kind of, there are many kind of delivery part that is kind of getting bundled into the health coverage kind of, proposals. And one thing we say in the book is that it's like two different things. And, let me use an analogy. Suppose you want to redesign the US Postal Service. Before you decide how many mailmen we need to have, how many trucks we need to get, how many planes we need to get, the first decision we need to make is like, what is it that we're trying to deliver? Are we trying to get people kind of mail every day, every week? once a month? Are we trying to get the mail to every place in the country, or only to some sort of, center of the town, and let people from the rural areas come back to the town center and kind of collect their mails in some mailboxes? So we need to decide what it is, the coverage or the service we want to provide, and then that helps us kind of decide how to build the right delivery system that is going to support this kind of, coverage kind of service. So the same with healthcare. Like we shouldn't be bundling these two. We should first decide what people should get and how kind of conceptually they should get it, and then we should kind of optimize the delivery system around this stuff. So that's, in that sense, the book doesn't talk at all about kind of the delivery part, which is like a lot of your question. Having said that, for sure, sort of, if kind of some version of this system works, I think what's likely to happen is that basically like more demand for basic services because more people will get it, and then probably demand for the higher end services is going to be somewhat lower. So you need to shift people from the high end experience to the lower end experience, and in some variety of way. But it doesn't mean that Stanford is not losing business. That there are enough rich people who are going to still kind of pay up and get this kind of concierge kind of type of medicine. Again, it's how to do the numbers because you need to decide exactly what's basic, exactly sort of what's not basic, and so forth. They lose you.
Oh, did we lose Kevin?
So,
Looks like we might have. You know what? We're just at 9:03 anyway. Is it okay if we, probably perfect timing anyway to close the
yeah,
session?
and if anyone has questions, I'm around. I'm in Stanford, so just shoot me an email. We can get them soon.
Wonderful. If it's okay with you, we have this recording. We're going to send it out to the whole community as well, so everybody can see it, and then we can also put your information in there to reach out. Thanks so much. This was a really wonderful presentation. Thank you for being with us today.
Thanks a lot, Aaron.
Thanks, everybody. Have a good day. Bye-bye.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.